So if you wouldn't mind just holding, we'll get started. Good morning, everyone. Thank you so much for joining us. My name is Samantha Mokas, and I work with FACOS. We are so excited to have this opportunity to present to you with our next installment of our free webinar Wednesday series, brought to you by our business partner, MultiPlan. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You should see an attendee interface on your computer desktop in your upper right-hand corner. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select telephone in the audio pane, and then the dial-in information will be displayed. You'll have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during this presentation. We will collect these and address them during the question and answer session at the end of today's presentation. With that, I'm going to turn the presentation over to Elaine, who is with MultiPlan. Thank you so much, Elaine, for being with us today, and we are excited to see what you have.
Thank you, Samantha, and thank you to everyone that's participating on the webinar today. As we were thinking about a topic that would be important to everyone, I was reflecting on the fact that the healthcare landscape is always changing. There have been recent news headlines on the CMS agency's Shared Savings 2019 program and the potential impact to ACO organizations in that program. In the private sector, there's been many articles on well-known companies that are starting to deliver new types of employee healthcare benefits delivery models. There have been a growing number of large self-insured employers talking about collaborating for new types of integrated healthcare delivery system models. So what we all realize, those of us that are working directly in healthcare or serving those companies that are working in healthcare, change is constant. Today, I'm going to be talking very briefly about one of those emerging healthcare delivery models, direct to employer. We'll be talking about the required business components and the best practices for accountable care organizations that are entering into self-funded employer contract agreements. And it's my great pleasure to have joining me today, Jack Hill, Executive Vice President of Accountable Care Solutions Group, known as ACSG, who we collaborate with to deliver a comprehensive turnkey direct-to-employer model, and you won't want to miss some of the very interesting experiences that Jack and his team has had in developing this model for the marketplace. When we look at some of the interesting statistics in healthcare today, of the 32 million insured individuals enrolled in or attributed to an ACO, commercial ACOs, we have found, provide care to approximately 59% of them. About 1/5 of the large employers are contracting with or promoting ACOs offered by the health plans, according to a recent member survey by the National Business Group on Health. And that movement into ACOs could accelerate, with a projection of potentially another 26% of companies saying that they were considering promoting or contracting with ACOs as soon as 2019. Today, there's over 150 million Americans covered under employer-sponsored health plans, and that number is expected to increase. Employer healthcare cost containment strategies, such as narrow networks and cost shifting, can impact an ACO's bottom line. Providers traditionally have played a more passive role in establishing prices with an insurer, serving as the intermediary. In today's direct-to-employer model, achieving the employer's success measurements are critical to the success of an ACO. And it's truly becoming all about the metrics, as we've been talking with ACOs and self-funded employers as to what their priorities are. Providers must achieve employer targets, such as hitting an annual financial budget, being accountable for key quality, cost, and utilization of services metrics on a wide range of services. And metrics, can include, but they're not always limited to, targets for customer service satisfaction. Is it improving with these new services? Preventive care approaches and their impact. Chronic conditions and how they're being managed to control a population that needs to improve their health. And ER visits, how can we reduce those as providers and hospital systems? ACOs that we've recently talked to this year have told us that they want to make a difference in their local communities. What is the opportunity for them? They want to become a more active participant in the direct employer relationship, in a collaborative relationship. They want to take back some of the control over profitability and find new or more improved revenue streams. They want to directly market services to the self-funded employers. And in a direct-to-employer model, the ACO supplies services to employees through a contract using very specific clinical and financial data to better target the healthcare needs of a specific population, and then measuring the progress and the outcomes. In looking at the blueprint, which is really today's theme of the presentations, we thought about how do we visually show the components of a direct-to-employer model to help an ACO organization really optimize their success. So I'm going to explain this chart to you, and we've color-coded it to hopefully make it a little bit easier to understand. But employers that we've talked to say that they want a rich, robust healthcare package with a national network coverage. They want full medical and pharmacy benefits and the analytics tools to help manage risk and cost. In a direct-to-employer model, through the lens of MultiPlan, we view it as a three-layered strategy with components in each delivery phase of the model. In the outer layer, blue, you have the heading Accountable Care Organization. In this outer layer, it's the primary layer of the healthcare services where the employer and the plan member experience the health plan and the core network component. The ACO is responsible for this health plan, the benefit design and the rollout, and the core provider network components. Where are the members going to go for their in and out of network services? The other three components in this outer accountable care organization layer include the program administration, the day-to-day operation and management of the model, pharmacy benefits coverage, and potentially stop-loss insurance coverage. If we look at these three components in the rest of the outer layer, as well as the inner two layers, which include population management in the light green and cost management in the dark green, the rest of this outer layer and the inner two layers, all those components are delivered by MultiPlan in collaboration with a plan administrator, which could be a TPA or an ACO, who's experienced in provider-based or provider-sponsored healthcare services. And then collectively, we collaborate and work together with the ACO to deliver the other components. So within the population health management layer, we have the important data analytics to really assess the program and the impact it's making within that direct to employer model. The care management programs that will be available to the members, whether it's health and management programs, whether it's a gymnasium membership, perhaps it's healthcare coaches and navigators to help that member on their path to wellness. Those are the components within the population management layer. And the third layer, cost management. What's going to be the network strategy to cover those members, whether it's a nationwide primary care network, whether it's a regional complementary or wrap network to supplement what the ACO already provides, and payment integrity. And payment integrity is becoming a more important area than ever before, really helping organizations review and verify that claims have been priced correctly based upon industry benchmarks and guidelines, and to assure that there's no waste and abuse from those pricing strategies, and hopefully that there isn't any other types of issues. So it's really a proactive approach to really providing quality control around the pricing accuracy of claims, especially some of the more complicated claims that we see today. So that's at a high level, the three layers and the components within each layer that are required for an ACO to create, launch, and manage a direct-to-employer business model. Let me tell you a little bit about MultiPlan and the services that we do offer that support a direct-to-employer model. MultiPlan leverages technology, data analytics, and a team with extensive industry experience, including a staff of physicians, nurses, and expert billing coders with many years of experience. And together, we utilize this talented pool of resources to create solutions that will combine payment integrity, network-based, and analytics-based services. Without going through all the statistics, we have been in business since 1980. We serve a wide group of payers and providers in America. And here are some of the vital pieces of information around the scope of services that we have offered and to the number of growing providers and other types of payer organizations. We are supporting today over 1 million participating providers in our networks. We have 200 million healthcare transactions that are being processed annually on the average. We have 400 payer electronic connections. We have 240 relationships with our valued TPA clients, and we've saved collectively, on the average, about $15 billion in annual medical cost savings. The markets we serve are commercial health, government, and property and casualty organizations. And I won't go through all of these, but I think you can see the breadth and scope of the organizations that we serve in most every healthcare delivery sector in America. The specific services that we offer, and we offer these to a variety of organizations, from our third-party administrators, the valued health plan clients that we serve, and of course, ACO organizations. And again, in summarizing those, we offer the important payment integrity services, which is really the analysis and the resolution services that can really address, from a prepayment perspective, avoiding waste and abuse. We have the network-based offerings of over 1 million provider contracts across all 50 states in the US to provide either nationwide or regional complementary networks. And then we have the analytics-based services where we really have the goal of reducing in a significant way the cost of care through negotiation services on behalf of our clients and different types of pricing approaches. So in summary, we support the direct-to-employer model through this blueprint strategy. I've got here my contact information. We have a lot more to cover, but we wanted to give Jack most of the time today. If you do want to reach out to me individually, here's my contact information. At the end of the webinar, Samantha will be sending out an email that will have a link to a MultiPlan page that will have more information on the direct-to-employer program, as well as the Accountable Care Solutions Group, their program offering as well. So with that, I want to thank everyone for participating, and I'd like to turn the presentation over to Jack Hill, Executive Vice President of Accountable Care Solutions Group.
Thank you so much, Elaine, and Samantha, I want to thank you also for allowing us to share some information with your members. I hope everybody can see my screen. Is that correct? Because I want to make sure I'm on. Okay, good.
Yeah.
Well, I just want to emphasize also that we as an organization have a long-standing relationship, probably over 25 years with MultiPlan. We use a substantial number of their services, and we treasure that relationship, and we think that those moving into this area are going to find a good partner in MultiPlan. I know we have. So we're going to talk a little bit about the direct-to-employer as it relates to what our experience has been working in this area for the last few years. And we're going to talk about what it is as it's defined, generally speaking, not always, but generally speaking, reasons why providers might want to adopt a program, some of the key value propositions around that, a little bit about our experience in working with these types of programs, different ways that you can adopt and implement, and then steps to implementing, how you'd actually implement. But we're going to also be talking about the financial elements of these also. But to begin with, the direct-to-employer program is I'm going to minimize this one screen I have here. is when medical providers directly contract with self-funded employers, generally speaking, for a fee-for-service with an upside gain share, there could be opportunities for some limited risk-bearing opportunities with employers. Those are typically done in after the provider organization sponsoring these arrangements has had some experience working with employers, and that's really where we think there's real value in doing a kind of a limited risk arrangement, so that you can start to transition toward more comprehensive population health. The core value proposition, and this is to me the game changer for providers, is that you're at the center of the relationship with the employer. It's not an intermediary, be that the insurance company, what have you. You are directly across the table with the employer, developing the relationship and talking about those things that really the employers want to discuss, and they want to know what the cost drivers are, what the illness burden of the population is, what you're doing as a medical provider to address my key concerns, which is the health and welfare of my population and my cost, my budget. So typically financial incentives are built into this, primarily to incentivize, align incentives between the employer and the provider, because in a fee-for-service environment, that never happens. But if you can develop gain share arrangements that reflect a targeted budget, you could work against that budget to achieve a particular favorable variance. That's an opportunity for the provider to be paid for actually working and helping an employer reduce their costs, rather than this thing that we're on right now in the fee-for-service environment. And in most parts of the country, fee-for-service is still the predominant payment methodology. The strategy incorporates plan designs that obviously incent utilization of the sponsoring organization. Some cases we have plans where they're primarily provider-centric only, so that if you go to the sponsoring organization, you have the highest level of benefit, and there may be little or no benefit if you were to voluntarily go outside the system, similar to an HMO. But at the end of the day, this is all a self-funded type of arrangement. There are 5, and maybe even more reasons, but 5 primary reasons that we find why a provider would want to move in this direction. One is producing incremental revenue. In most markets, you don't have that are in urban markets. You don't have a dominant player that gets 80% or more of the actual medical steerage revenue. So this is an opportunity for the provider to have a product that specifically steers patients toward their provider organization for various reasons. One would be unit pricing issues, where they can reduce the unit price to build the incremental revenue. Because in most organizations that we talk to that are health system oriented, they have a facility, they have a hospital-based system, incremental revenue generates the highest level of margin, because you already have your sunk cost. You know what your marginal cost of operating an entity is. That's true even with physician group, but that's a major key issue. The other is control over your network. When we get engaged with providers that want to set up their own plan, many times they may be organized for an MSSP, they may be organized for some levels of commercial business, but they may not have the full complement of medical service delivery. This is an opportunity for you to create your own network and your own product. And just doing that, in many cases, allows you to better recruit other providers that you heretofore may not be able to get, because if you're just a passive provider network or just an MSSP for Medicare shared savings. It's an opportunity for employers to directly connect with local medical providers. I can't tell you how many times I've talked to either providers or employers who have a desire to do it, but no one has a clue as to how to come together. And so this is an opportunity to do that in a turnkey way. It provides a sponsoring provider with a low risk means of being able to move into this area of direct to employer and be able to obtain other sources of revenue and other sources of value that you wouldn't otherwise be able to do. And at the end of the day, You want to increase satisfaction. You want to achieve better outcomes and reduce costs, because there's a reason now for me to do that as a provider working with employers. The financial impact, as we said earlier, is really key, and the primary area is in the sponsoring organization as the primary medical delivery system. And this is where working with MultiPlan actually allows us to do a quicker, faster, more robust means of providing a full complement of medical services. Most ACOs in the United States, and even most health systems, even large ones, don't provide medical services for every component of care. They may not do certain subspecialties in pediatrics. They may not do certain quaternary services or transplants. You're going to have to round out the gaps of care in a manner that's going to allow you to actually deliver full complement of services. So that's where MultiPlan comes into play. We can discuss that at another time, but that's you're the primary network for those services that you do. Plan designs restrict access to other providers. You can put in various protocols for how the patient navigates through the system in terms of referral management, things of that nature, which can be delivered. And then at the end of the day, if you do those, you achieve a number of favorable financial gains. One is gain share distribution, and we'll get into more detail in a moment. Medical services not otherwise paid in plans. When you get into these arrangements, a lot of times providers don't achieve full medical services in a plan because there may be elements of regimens of care, things like that for the chronically ill that they normally wouldn't get in a standard plan, that's administered by the Blues or Aetna, United. Here, what we're doing is we're creating a care management system that creates an actual reason why a patient would want to access your delivery system, and that is that I have identified 27 chronic disease states and comorbidities. Each one of those, in most of these plans, is paid at 100% only to the sponsoring organization. So it's another area of medical service revenue that you normally wouldn't get. And the other area could be access fees. Since you're building your own network, you're going to want to charge some amount to incent yourself to build some administrative revenue on the top end. And at the end of the day, I've calculated in one part of the country, locale, 3,500 members down up to 12.5. And what we've calculated based on, and I'll show you more detail further on, is what the DTE, the direct to employer net revenue, represents for 3,500 members. And that net revenue is a result of steerage into a network, but what that represents also is 7.9 million with 3,500 members of incremental revenue. That's a huge amount of revenue for a relatively small number of members that you could obtain through these arrangements. Increased net revenues can go from 30%, let's just say that you're in a market where you're one of three major systems of care delivery. It could be a large physician group that you are part of, or a clinically integrated network. Whatever it is, if you have around 30% market share, these programs, by those people that buy them, are going to inure at least 70+% indirect allocation of medical services in your network. And we'll show you how that happens. The 3,500 members we mentioned earlier is based on a review of medical claims that in a particular market. So let's say this is Detroit, okay? And the medical service claims for 3,500 members in column 1, claim revenues is 16.4 million. That's how much medical claims revenue are representative of 3,500 members. In the second box, where we talk about the current passive PPO, that represents a 30% market share of that 3,500 members. So if my market share for that employer is 30%, I'm generating approximately 5.5 million in gross or net revenue from that arrangement. Okay, and if the variables are equal, that my market share is completely reflected in that 3,500 members. 30%. Now, if you go into a DTE program and you use the right plan design, protocol, plan steerage in the plan, you can go from 30 to approximately 70%. And that's just a basic calculation, which represents 12.2 million of the medical service revenue that you would be getting in gross revenue, or 6.7% of additional incremental revenue. What I've also calculated in this pro forma is direct to employer network fees of 210,000, chronic disease management fees that you wouldn't otherwise be getting if you weren't a narrow network of 375,000, and 640,000 of gain share based on the collective 3,500 members meeting the standard reduction in their annual budget, reduction underneath the annual budget. And that gain share is based on our current book of business of over 3,000 self-funded plans where we don't have a direct-to-employer plan. So I'm being pretty conservative with that number, but look at the difference. I'm going from $131 PMPM on a medical service revenue arrangement to $320 in a direct-to-employer with the same 3,500 members. That's just to give you an idea. Now, in these arrangements, we always input the gain share distribution strategy and contractual arrangements that the provider would have with the employer. And in this case, the actual budget, the targeted budget for this plan is $500,000 in a year. The calculation would be if I, as an employer, come underneath that targeted budget, and 99% of the time, that $500,000 targeted budget, I'm already saving money, because otherwise I would not have bought a narrow network product. So if I come underneath that targeted budget, the calculation would be 50% of the favorable variance. So if I come in 200,000 underneath that budget, 100,000 I'm going to share with the medical provider that sponsored the narrow network, and I will, as the employer, retain the other 100,000. That's typically how they work. Now, the employer, a lot of times I hear from providers, why would an employer want to buy this? Well, in most markets that we work in around the United States, these arrangements can be provided to employers as small as 2 employee lives. So the ability to adopt a full narrow network replacement plan is obvious, because small employers typically only offer employees one option. Even if you went into a dual option, employers could still offer a full replacement for a narrow network product. But the employer's interested in reduced medical spend. They're just price intolerant in today's environment. They're just tired of the constant increase in premium cost every year with no explanation. So you're going to find a lot of people going to adopt, especially in markets where community ratings are 100 and below. And I'll explain that if people have any questions about it. In 99% of the time, we're going to have better competitive stop loss rates and attachment points. What I mean by that is most self-funded employers that have under 5,000 employee lives will buy some form of medical stop loss insurance coverage. And that is so that the employer and the reinsurer who are at risk, the employer wants to mitigate their risk for catastrophic individual claims or claims that accumulate to an annual attachment. So they're going to buy that, and these plans always have the most competitive stop loss rate. They like the idea of increased flexibility. In other words, I can work with the medical provider collaboratively to adjust my plan design structures to account for changes in utilization, okay? And through the analytics that we provide, you can hone in on those relatively quickly and make the appropriate changes when it's necessary to mitigate risk or to adjust for other conditions in the population. Because these plans are self-funded, there's increased cash flow and stabilization of cost over time. Because the provider is now attuned to your budget, they know monthly, weekly, where you're at from a claims standpoint, from an illness burden standpoint, you're all going to be working together to stabilize those costs because you're going to intervene at the appropriate time because you have the data, you're working collaboratively, and you both have an eye on the budget, okay? That stabilizes cost over time. Employers like the plan design options. So if an employer wants to, they can build as high or minimize the impact of steerage depending on their circumstances. A lot of employers have union considerations and others that would have an impact on how plan design options are provided. So employers like the idea of being able to have flexibility in that area. A la carte administration. These plans, we could offer a turnkey opportunity for an employer to do a single source purchasing of services. So not only do they can they get into the medical plan under this direct to employer narrow network arrangement, but they can also get access to other benefits that they want to buy, but don't want to separate it out to multiple different types of service providers. We can do it all in one operation, dental, vision, anything that they want. Incentivize care results. Employers like the idea that providers are now finally accountable for the services that they render, because now I, as the employer, have the same data that the provider has to evaluate how well they're doing and how my plan is doing. And that is, I think, a key value proposition that providers can now offer. Improve and superior analytics. We have incorporated a data analytics capability from one of our other companies called the American Health Data Institute, where we've been doing analytics since the late 90s. We have over 4 million in our data analytics database, where we can provide some means of being able to model out specific health index of the population, individuals. We can look at illness burden. We can look at regimens of care. We can look at completion service rates for the chronically ill. We can work with the provider of, in this case, the ACO, the medical provider, to help them understand in an employer-sponsored, self-funded environment how to work with that employer. Because employers many times are not used to having clinical evaluation of claims data. Now we have an opportunity. It just adds another element of value. And care control. They like the idea that now not only is the plan design steering my patients to physicians and providers that have lower cost of care, but that they're being actively managed at the same time. Program description could be done a number of ways, and I'm just throwing this out as what we've seen in the marketplace as some ways, and what we've actually done in reality with some providers is a lot of providers that don't have complete 100% medical service delivery of all the necessary services wrapped up in your primary network. You're going to need a tier 1 network. You're going to need primary care as a key component. You're going to need other types of services, ancillary, mid-levels, so on and so forth. But in many cases, you're going to need a tier 2 network wrap like MultiPlan. And the reason for that is you're not going to be able to deliver everything to begin with. It may take time before you're able to basically contract locally with every provider that you would need to have to own your own core network. But MultiPlan is key, because if you put these plans together right in your core network, you can establish referral management protocols so that when an employee is attributed to your network, they select your primary care doctor. They are going to, obviously, as they can tend to utilize tier 1 providers, get tier 1 benefits. It's obvious. But if they go to a tier 2 provider and it's a service that you don't provide, you don't want to penalize the member. The one way to do that is to build in a referral management protocol that allows you to control the navigation of that patient to tier 2 or tier 3 providers for services you don't provide. So you have control as to how that patient navigates to tier 2, which is typically at provider contract rates that are a little higher than tier 1. But you control that. That's why the tiering of network arrangements are typically favorable, especially when you're starting out. the next area that's key is that once you've decided to actually move in this direction and you want to deploy your own program, you're going to have a robust means of messaging out that program. You're going to have to develop a brand messaging strategy. You're going to have a means to direct sales into the brokerage marketplace, because brokers and agents still control the lion's share of how employers buy. So it's a reality of the marketplace. You're going to have to deal with them. That's where we can help you. Access to your own benefit plan structure. So if you have a sizable employee force, you might want to practice on yourself as you're taking this out to the marketplace. A lot of times, I've heard many times employers in the community, when they've been approached by networks that have deployed these DTE programs, well, what are you doing? You know, why you're asking me to buy this program? What are you doing in your own plan? So it's an area you've got to consider. It's not mandatory at any level, but you should highly consider it. And then you have to have a competitive stop loss rate so that you can actually deliver a program that has the pricing behind it. Because even though direct employer plans do not put risk on the provider, the risk taker does become the stop loss carrier and the employer. So you've got to have them on board. They have to have the right motivation to want to participate in these arrangements. And we've got about 15 different carriers that we've worked with for this whole purpose. And then at the end, you're going to have brochures. You're going to have to message out your program through media, websites, media, brochures, what have you. Give you a little idea about us. We've, as an organization, I'm part of the Key family. We've been around for over 40 years. We have DTE integrated in our reinsurance and our medical stop loss arrangements that we have. We actually work in all 50 states, but I think last year we wrote business in all states but Montana and Hawaii. We have a turnkey, completely customizable administrative infrastructure. So we handle everything directly: claims, customer service, fulfillment, compliance, reporting, referral management, mobile apps. And we sync that capability with any medical provider delivery system that we work with. We work with MultiPlan on the network wrap arrangement. So as we start to understand the medical services, the level of services that the sponsoring organization has, we then identify the gaps in those services, what has to be filled, and that's where we can work with MultiPlan on a very favorable basis to arrange that. And these are mostly one-sided gain share distribution arrangements, but if you so choose as the medical provider, you can do both upside and downside depending on the circumstances, and we can discuss that. I'm going to give you just a real quick down and dirty on some of the providers that we work with where we've implemented these same benefit structures and chronic disease management structures. Here's a Midwest physician group of about 4,900 members. And when we started in 2014, they had almost no real chronic disease completion rates for the chronically ill, regimens of care for that. But as we've increased those, we've been able to reduce the actual claims cost against their actual trend to a delta of $15 million, of which they would have not gotten if they hadn't done their own program and managed and practiced on their own population. Same is true for an acute care hospital we've done this with. In over a 4-year period of time, they've built a $47 million delta based on managing their own population, managing the referrals to certain specialists and other types of diagnostic services, and then actively increasing the completion rates for those chronic disease members that they had in their plan. This is just an idea where we've mapped out the roles and responsibilities. And if you can see in the bottom left-hand corner, that is where the sponsoring medical provider is going to spend most of their time, because 90% of the work we do when we help providers implement these types of arrangements. But the provider needs to establish a Tier 1 provider delivery system. They have to be able to recruit other providers that are going to be necessary to round out certain aspects, key core aspects of their network. They're going to have pricing and contract terms that are favorable so that they can drive members to their network and build that incremental revenue that's so key and critical to these arrangements. They're going to have to be able to approve and have somebody available to, as kind of the medical director, Attila the Hun, to review pending referrals and evaluate them based on clinical and cost, and then make those approvals. Medical oversight, you're going to have an ongoing practice improvement program for most Medicare MSSP ACOs. That's not going to be a difficult thing because most of you already have that in place. And you're going to have to determine how you're going to distribute your gain share once it's calculated, and we have dollars that have been allocated based on an employer's actual results, favorable variance to the result. You're going to have a means to know how to distribute it. It should be a written formula. You should communicate it to your doctors so that at the end of the day, when they get that distribution, they know why and they know how it was calculated so that they can actually quantify it. Because a lot of times I dealt with providers over the many years that never knew why they got a bonus distribution. They just appreciated it. For us, as an organization, when we put these programs together, we will not compete against the local provider sponsor that we work with, unlike the insurance carrier environment, Aetna, United, or Blue Cross, or Cigna. In those instances where they do narrow network arrangements, they can also compete with you in the same market with other products that they have. That'll never happen with us. Our objectives are aligned with the provider. At the end of the day, we're at the hip and taking these programs out. We're completely transparent, and this program in general is completely transparent relative to fees and utilization and information, what have you. And then we have the size and scale specification to be a good partner for anyone in order to compete effectively in the marketplace. Most of these arrangements are going to take between 4 and 6 months to develop, sometimes longer. A lot of it depends on the complexity of the organization and what it is that they want to achieve. And generally, we'll start off with a scoping document. We'll have discussions around exactly what is to be achieved, the level of medical services that are currently offered through the sponsoring organization, so on and so forth. And that really takes the majority of the time, especially if you are a physician organization and now you got to go out and actively solicit direct facility contract. That takes time, and we can help you with that. But typically speaking, if you have much of that stuff in place or could be in place in a very short period of time, you could be in the marketplace in 6 months or less. And for those of you interested in more information, you can get a hold of Elaine at MultiPlan or myself, and my information is right there available for you. So with that, I'm done, and I hope I didn't bore anybody.
Thank you so much, Jack. Definitely not bored at all. It was very, very insightful. I do have a few questions for you. One for Elaine. We are an ACO and already use companies that provide some of the components you showed in the components layer table. If we have service gaps under the DTE model, does MultiPlan know companies that we can use?
Absolutely. We're really here to collaborate with all organizations that want to enter, the DTE model, and we certainly can be a referral source. We have relationships either directly or indirectly with a variety of organizations, whether it's a PBM or stop-loss carriers, and we often, talk with Jack. If we don't have a potential referral, Jack will always, give us some good ideas. So absolutely, we're here to complement in the case of the ACO, we will complement the services that you already have that are working well for you, that you offer directly or through your own relationships with other vendors, or we will refer solutions to you. And in some cases, if you don't already have a service, we can provide one of our 3 services that we mentioned to support your direct-to-employer model. Thank you for the question.
No problem. Thank you, Elaine. Jack, I have a few for you as well. What differentiates the DTE approach to other narrow networks in the marketplace?
Well, I think what's different is that these are primarily belong to the provider. It's their program. They're the ones that are driving the boat on these arrangements, and we become an enabler for the provider to be able to actually have the relationship with the employer. Most of the time, that's not the case with most other narrow network programs. I haven't even seen one, unless the provider is directly doing everything with that employer. There's some isolated instances like that, like with Boeing and Memorial Care and things like that. We've seen those on a direct basis, but there's always an intermediary. In this case, it's Blue Cross of Illinois. So the provider in our arrangements is the one that can own that relationship. That's not really true in most of the ones that we've seen in the marketplace.
Gotcha. Thank you. And then how long does it take to implement these plans? And what are the key aspects that we as providers need to know in order to launch a successful program?
Normally, I mean, depending on the complexity of the network, what it is that they have in place today, and what they need to round out their network with in order to deliver a full complement of medical services, it could take a while. And the biggest challenge is if you don't have a hospital contract. Let's say you're primarily a physician network, and you need to have a tertiary contract for the majority of your tertiary services, referrals. That's going to take the most time. If you have complexities around antitrust, in other words, if you are not fully clinically integrated with every provider you might contract with, that's going to take some time. Either you're going to have to clinically integrate with them, or develop a messenger model, or work with MultiPlan. You can work with MultiPlan and eliminate the full impact of antitrust and still have your own controlled narrow network. But a lot depends on what you have in place and what you have to round out your network with. That's going to take them. But most of the time, if you have most of that in place, or if you work with MultiPlan, we can do it for 6 months or less. We can get you in the marketplace with a program.
Okay, thank you. And the last one I do have is, what is a good provider organization structure in order to accommodate these programs?
I don't think there's such a thing per se. There are every kind of organization we work with. We work with IPAs, we work with PHOs, we work with health systems, we work with fragmented multi-hospital systems. I mean, you've seen one, okay? But I'd say optimally, if you have primary care as the driver, you have enough leverage to create optimal contracting with hospitals, you're in the sweet spot right there.
Thank you. Thank you again to Elaine and Jack for taking the time to present this information to us today, and thank you everyone for participating in today's webinar. Once you exit, you'll receive a survey on the presentation, and we would appreciate if you would complete that. We also will be sending an email with contact information if you have any follow-up questions, and a link to the webinar recording. Please feel free to share with your colleagues. I also wanted to remind everybody that we have our Fall FACOS conference coming up in October in Orlando. For more information, visit our website. We hope to see you all there. And again, thank you and have a wonderful day.
Thank you.
Thank you.